My name is Carla Sutter, and I am the Director of Operations here for Synergy HomeCare. We have offices located around the country in 37 states and look forward to being able to present these educational webinars every month. And we'll talk about May's webinar at the end. I'm just going to do one more sound check and make sure that you can hear me. So if a couple of you would like to log in and just say yes, that would be great. So I do want to make a disclaimer that this webinar is not meant for financial or legal planning purposes and is educational in nature, and that before you were to make any legal decisions or financial decisions, you would want to work with your own team of advisors to determine what is the best fit for you and your family. So the elephant in the room, that is advanced care planning and healthcare directives at its best. Today we are going to be talking about communicating and documenting your healthcare wishes, and this is a perfect time of year because April 16th is designated as National Healthcare Decisions Day. I think that it is more accurate to talk about this as at least a month, because there are lots of time to be able to share with family and talk about this and bring this topic up. Of course, this is a year-round topic of discussion, but we have moved forward in at least making this something that comes up every year, similar to taxes having to be paid and our putting in our paperwork. Healthcare decision making and communicating and documenting healthcare decisions is very key and important. I want to go over some numbers that I think are really interesting, and this was done by the Conversation Project and a national survey that showed that 90% of people say that talking with their loved ones about end-of-life care is important. However, only 27% have actually done so. 60% of people say that making sure their family is not burdened by tough decisions is extremely important. However, 56% have not communicated their end-of-life wishes to their loved ones. 80% of people say that if seriously ill, they would want to talk to their doctor about wishes for medical treatment toward the end of their life. However, only 7% have reported doing so. And 82% of people say it's important to put their wishes in writing. However, 23% have actually done so. I think those are really powerful numbers, and I think it really speaks to why this is such an important topic. I think it's really timely when we think about the recent death yesterday of Barbara Bush and her choosing comfort care and certainly communicating to her family members and her loved ones what her wishes and choices were at the end of life. And I hope that those type of more public determinations allow all of us to be able to have those same types of conversations with those we surround ourselves and are important in our lives. It always seems too early until it's too late. This is such a key quote that really speaks to why today's topic is so important, because again, none of us know what's going to happen. You know, you think about all of the news events that are occurring and the recent plane crash that we just saw a few days ago. And again, none of us think that now is the time to make decisions, to do documentation, to have conversations with our loved ones until it's too late. And we'll talk about as we move forward why it's sometimes too late, even though we may still be here and decisions still have to be made. I want to share that part of my background and the reason that I'm speaking of this today is that in my 30 years of working as a social worker and working in the healthcare continuum is that I've had both the honor and privilege to work with clients who were at end of life and making very difficult decisions due to advanced illnesses, and also with my work in hospice, being able to see how families and clients who had communicated information between each other were really able to then focus at their end of life on other kind of important conversations and discussions because they knew that this was one that had already occurred. And I think it's really key as a trainer for many professionals and clinicians on having and holding end-of-life conversations with their clients and patients, recognize that there is no professional who is even in the healthcare industry that is not part of those numbers that I spoke of, not part of the group who want to have these conversations but haven't, say how important it is to document but haven't. And so I speak to both family members, clients who may be on, but also the professionals and those who are having these same conversations, that these documents, these conversations are as important for you to have with your loved ones as it is for you to have with your clients. Advanced healthcare directives and honoring choices is what our topic is today, and I really see that these documents reflect the voice of the heart. They are a gift to family members and a way to ensure our wishes. As we move forward, if you do have questions or comments, please feel free to put them into the question box. While I will not be answering those questions as they come through, I will be doing it at the end. And I don't want anybody to miss or not remember a question or a comment that they wanted to be expressed. So I want to talk about the objectives which for this topic, which are going to include defining advanced care planning, understanding one's options for healthcare documents, learning who can speak for you when you can't speak for yourself, how to initiate this crucial conversation, and then talk about next steps and share resources and references. So why should this be a concern to you or any of us? The reality is there is no easy way to plan for healthcare choices. It is a process that involves careful consideration and communication about sensitive and sometimes complex situations. But the facts about how we die are clear. Most of us will die after experiencing a chronic, progressive, and ultimately fatal illness. Approximately 80% of deaths will occur under the care of health professionals in some type of health organization. And when the time comes to make important end-of-life decisions, approximately 50% are incapable of participating in those decisions. And that incapacity comes because of the level of distress that they are under, physically or psychologically or cognitively due to the illness itself. They may be on medications which make it very difficult to be able to focus on this topic. They may have, again, changes in cognition that does not allow them to have these types of conversations as well. When health professionals are uncertain about what decisions to make, the default will always be to treat. If health professionals or loved ones have not spoken with a patient about end-of-life issues, they cannot reliably predict what the patient would have chosen, and they find the decision-making responsibility burdensome and stressful. As we move forward, I'm going to utilize the term loved one versus family because I think, as we know, that the family label often then minimizes the group of people that one has surrounded themselves with and wants to be inclusive of for decisions at end of life. And so we will utilize the terminology of loved one in place of a family member. So what is an advanced care planning process? It is really about a conversation that takes place between loved ones on end-of-life care wishes and preferences. However, it is not that this should be taking place at the end of one's life, but really during one's lifetime where they remain healthy with lots of choices ahead of them in terms of treatment options. It is a process that identifies what is most important to you concerning quality of life and living. There is no right or wrong in advanced care planning. Your decisions and values are simply your preferences and your decisions for end-of-life care. These are documents of choice and not of limitations. People will often say, I just am not ready to make a decision and document what I want. And the reality is that they have made that decision by not completing a document, because not completing a document has made many of your decisions for you, because as I shared, that if there is not a decision in terms of limited intervention or what somebody wants, the default of the healthcare team will always be to treat and to attempt to do what they're able to do from a medical intervention. So not completing a health directive is making a decision. It is making a decision to receive all the care from the medical facility until no more care and no more can be done. So let's define advanced care planning, because there are different levels, and oftentimes what gets in the way of people completing documents is the process itself. Advanced care planning is really the facilitated process. It's the conversation. It goes beyond checking a box on a form. An advanced directive, which may also be called a living will, depending on the state that you're residing in, or a healthcare directive, is a patient-directed document. We're also going to discuss POLST, sometimes referred to as MOLST or MOST, which are provider orders used to translate patients' wishes into a medical order. So as we move through, again, these are some of the terminology that you're going to be hearing. So why today is the day to have this conversation? Many years ago when I was a hospice social worker, these kind of conversations were a daily kind of activity as part of my role with my clients and families that I was working with. And because I was seeing so many different things occurring and a variety of diagnoses that had a variety of symptoms and interventions that could be or were no longer able to be attached to them, I was always thoughtful about what I wanted for my own health care. And my husband, who is not in the medical or healthcare arena, would often listen to me coming home and sharing my beliefs and what I wanted and the wishes that I was documenting on my healthcare directive. But oftentimes, because again, this was not his arena, he would just nod and say, really probably half listening because it's something that was coming up so frequently, and his comfort level with it was certainly not at the point where mine was, and I really hadn't taken all of that into account. So we were driving one day and a particularly difficult situation had arisen that I was working with for a patient, and really got me thinking about some different ways of approaching my own decisions about healthcare. And I shared it with him, assuming that as before he would just kind of nod and say, okay. But instead, two things happened. The first is it was a strong reminder that difficult conversations should not be occurring while one is driving down on the highway at 70 miles per hour, because it can be often fairly jarring to the occupant and the driver themselves. So that these are conversations that really need to be taking place in very comfortable environments where focus can be strictly on the conversation itself. But what it really taught me more than that was that these are decisions that have to be communicated between you and the loved one that you hope and want to be your decision maker. Because initially what my husband said is, if that is the decision that you want, I don't know if I can follow that, and that I'm not sure I can be your decision maker. And had I not started the conversation, had we not begun to talk about this, and instead I had simply documented this on my healthcare directive, and he had simply seen it at the point of a crisis where the medical team came to him and said, in reviewing your wife's document, this is what she is stating are her wishes, and you as the agent would be, verbalizing these to us, he would have then been put in a very difficult situation to be able to kind of think about his own belief systems versus what he knew that I had documented and wanted. And so again, it's a reminder that when you do have decisions that you have made, that it's so key to not just document them, but to really communicate them to those in the family, to those loved ones who are going to be part of the decision-making process. Sometimes people aren't able to be your healthcare agent because it is putting them in a very difficult situation. And I see that those who have been appointed as an agent, as your healthcare power of attorney, really are your voice for the decisions you have made and not decisions that they want. And not everybody is able to be put in that position. So it's important to think through that, and we're going to talk later in the session a little bit more about making those choices. The other story is really about a crisis story and really speaks to why it is never too early to plan. I knew somebody years ago who was a young woman who was in a relationship. There was not a marriage at that point. She was a fiance. And a health crisis occurred for her fiance that put him in a very critical situation, and he was not going to survive. While they did not have the benefit of marriage from a legal perspective, she was in a lucky position that his family saw her in that same role and gave her all of the responsibility and the legal kind of role to be able to make those decisions as his next of kin, even though she did not have the benefit of that from the legal system. But as part of that, he had a son, and as they talked about some of the difficult decisions that had to be made, including whether to donate any of his organs, it was his son who had just recently received his driver's license and shared with her and the rest of the family that when he went to get his driver's license, his dad said, I will not sign for you if you don't put down that you would be an organ donor. And they talked about organ donation and what it meant and really talked through that whole process. And so his son knew how important organ donation was to his dad, and he was able to speak up and say, I know what my dad would have wanted. What a lovely ability for him to have had this story, to have known how intent his dad was about organ donation and his wanting to do that. But what a difficult burden he was placed under, that he didn't have the benefit of that being completed in a document that he could then bring to the family and show them, and yet he had to kind of speak up from his memory. A strong memory, but one that, again, was not benefited from the documentation itself, which really is the added gift that these conversations lead to, so that one does not have to question in any way if that was the last conversation they had with that person and represents where they stand today. When we talk about advance directives, these are legal documents, and that in all states there are going to be some specific guidelines that need to occur to be able to make it a completed document and one that your healthcare team could take and could stand up to. This is why it is so key that you understand from any legal perspective within your own state, and by working with your own legal advisors as to ensuring that you have completed in the best way that works for your location and your situation. These documents are often created before serious illness, and that is really key because it's a document that we'll talk about later. This is a fluid document. It doesn't stand once and then represent your wishes for the rest of your life, but it is important to see this throughout your lifetime because different issues will arise and different reasons for needing this will often come up. When we think about younger individuals and why they would need this document, well, certainly there is disease that can happen, but oftentimes we're talking about accidents or situations that could be a traumatic event. And those will often lead to different types of decisions and different types of medical interventions in different ways than if it was a progressive disease that allows somebody to kind of see how the symptoms are progressing and how they are reacting and responding to any medical intervention. These are documents that are used to communicate the person's wishes to family, physicians, and other providers. They are used to prevent legal and moral problems. And we only have to look back now what's probably at least almost 30 years when we think about the Terri Schiavo case down in Florida, which really brought to the forefront the enormous impact and importance of having documents, because here was a family of a younger woman who did not have a completed document, and although she did have a husband, which would have been defined as her next of kin, there was a lot of tumult in the family and ended up having a court case based on the decisions that different people in the family wanted for her. These documents allow a person to be assigned as a healthcare agent, sometimes known as a healthcare power of attorney or a medical power of attorney, to speak on the person's behalf should they not be able to communicate themselves at that time. Many studies have revealed that more than 60% of individuals aged 18 or older want their end-of-life wishes to be respected. However, as we talked earlier, only about a third of them had completed an advance directive. So why is that? The first is pretty evident, where there is certainly a resistance about thinking about death. You know, we often have this kind of myth that if we, sign the life insurance or sign an advanced care plan, that something's going to happen. It's going to kind of bring upon that very thing that we're discussing. And while we know that that is not true, we still have concerns in certainly our society and culture about discussing death and having these conversations and knowing how to bring them up, even with our closest loved ones, because it feels that we are kind of bringing upon the Grim Reaper. For others, it's really not being aware of advance directives and their availability, really their ease of completion, that there's not a healthcare provider who has brought this as a question to see if this is something they wanted to explore further. So oftentimes it's just a non-awareness of the document itself and what it can do. There are some incompatibilities with some ethnic cultures in terms of writing down wishes versus it being a much more spoken language and a spoken conversation. And so that doesn't always fit with what then is required in a healthcare setting. There's also often differences in who is appointed in those family systems as the decision maker, even if it does not fall within the kind of predicated kind of legal determination of who is the next of kin. Sometimes just the technical language and the legal requirements in terms of what makes it a completed document and how do I speak the wishes that I have and that I know in my heart and my head, but I'm not sure how to communicate that in writing. And again, sometimes it's the inconvenience or irrelevance of a discussion at legally mandated times. For instance, when you're admitted to the hospital, there it has to be a question that is asked if you have a healthcare agent or a document, a living will, or an advance directive. And often it's a checkbox, which is a yes or a no, and there's no kind of coming back to that person and saying, let's talk more about the answer that you provided. And if it is no, would you like to have someone have this conversation with you? And if it is yes, does that document continue to reflect your wishes based on where your health stands today? The other is that there's often poor preparation or motivation of the personnel who must initiate these discussions. As I shared, there is no higher a completion rate for healthcare professionals than there is for the average individual and person. So that there is, even though we would be, it seems odd, there's as much discomfort with completing one's own document as a healthcare professional and then having those conversations with others than there is sometimes just with the non-healthcare related individual. Completing a healthcare directive is more about thinking about what we believe and what we value, which are shaped by the experiences we've had, religious, family traditions, history, as it is about our own present health status or health history. When we think about the present, do we have any present health issues? Do we have a family medical history that's concerning, something that you have seen in the past, family members who have experienced certain things that have a higher genetic tendency? What short and long-term goals do you have? And what do you define as medical success? That's a really key question, because when we think about some of the decisions that we can make on these documents, the biggest one being really around CPR and whether someone would be resuscitated if their heart were to stop. We have to understand what is medical success versus what is the ability for that intervention and treatment to bring back one's heartbeat. And so for some, the medical success would be about bringing one's heart back to rhythm, where for others, it would be about bringing their health status, their cognitive status back to where they were prior to the incident itself. And so really thinking about those factors as we think about the decisions we're making. Are there significant health issues that you could face in the future? Do you have a chronic illness that is going to progress, and that there's an understanding of some of the symptoms that will come up and some of the treatment decisions that will have to be made, and have you accounted for those as you're looking forward? And have you had those conversations, or has your physician had those conversations with you about what to be considering and thinking about as you move forward in the future with this chronic progressive illness? And how would decisions be made, and by whom, if not by you, and not by the person you've designated? And does that person reflect the wishes that you would have chosen if you could document them, and or appoint someone different than who legally would be viewed as your next of kin and the decision maker? Choosing a healthcare proxy. Consider that this person is the voice for the decisions that you have already made. But there's a lot of challenges in making this decision. Oftentimes when I've spoken with individuals who have not completed their documents, one of the reasons is that they don't want to feel like they're playing favorites, particularly if they have, many children or siblings, and they don't want to play favorites by appointing one person. And really, again, if you asked all of the different people in front of you that would be part of your kind of choice, many of them, when they understand what this entails, would really say, I don't feel like I'm the best person. I really think that, Annie or Mary would be better. And there's ways to document that the other members of the family or the other children, the adult children, would have access to speaking with the physician, would have access to medical records, but in the end, it would come down to that one appointed individual to be the final voice in the decision. One of the reasons that people don't complete these documents, as we talked about on a previous slide, is for the same reason that people with young children often don't complete a will. we all know that having a will is so key, particularly when we have young children. But the most difficult question to answer when you have young children is that if both of the parents were to die, who would raise the children in their absence? And very few people want to make that decision, and then really even more few want to communicate it to the other side of the family, who may not be the ones who are appointed as the guardian. And so they don't do anything at all, which again has made a decision in that situation to go into probably a court setting. One of the other reasons is we always think there's time, and so we don't complete this, and then when there's not time, there really is no time, because now it is too late for that person to be able to communicate what their wishes are. There are so many diverse family situations that often those family situations work well until a crisis. I talked about that earlier example where there was not a legal designation as a spouse in that situation, but that the family of the ill person did say, we still want you to make this decision, but that often does not happen. And so people in a crisis, even in the best of family dynamics, will often become unable to kind of let some of that control go and want to be making the decisions. And so having a document that represents one's wishes then and now will allow for the right decision maker for you to be able to step up. There is in every state a very delineated structure as to who is appointed as next of kin, and that can be found in any of the state statutes as to who would be next. And again, sometimes while it could be a family member, a parent or adult child, it's not the one you would choose, and you would maybe go farther down the list to someone you have a stronger, closer relationship with, who you would want to make those decisions. How can you plan for all the future healthcare options? Providing instructions for future healthcare decisions can often seem like an impossible task, because how can everyone plan or anyone plan for all the possibilities? The reality is that you cannot and you don't have to. Instead, consider some of the following questions. When would it make sense to continue certain treatments in an effort to prolong life and seek recovery? When would it make sense to stop or withhold certain treatments and accept the terminal nature of my disease or situation? Under any circumstances, what kind of comfort care would I want, including medication, spiritual, and environmental options? Again, often these documents that lead up to more medical orders, such as post-provider orders for life-sustaining treatment, are really more of a conversational document that you can then really know what your wishes are and more easily document the specifics. I had a client that I worked with, and the father was very ill. He was in hospice for advanced Alzheimer's. He continued to have choking as he was eating, which is a natural progression of the Alzheimer's symptoms. And because of his choking on food, he would aspirate, so that he would bring food into his lungs and it would cause an infection and pneumonia. And this was happening more and more, and he was needing more and more treatment for these pneumonias that the family wanted to continue to treat. And so they were making the decision about, hospice being the best option, or what other treatments or interventions, and did they want to put in a feeding tube because of all of the choking. And the daughter really couldn't make the decision. She didn't know what she should do. And I asked if there was a healthcare directive in place, and there was. And so together we reviewed that healthcare directive. And after she read what her dad had written, I asked if she knew the decision she wanted to make, and she said yes. It was very clear. And what was interesting is, and it doesn't matter the decision, but what does matter is that he didn't document a intervention directly. He didn't talk about any medical treatment by name, but he did talk about what was important to him for his quality of life, what was important for him in terms of medical success of any intervention or treatment. And just based on those more conversational ways that he documented in his advance directive, she was able to make the decision that she knew represented what her father's wishes were, even though he hadn't specifically documented anything about whether or not he wanted a feeding tube. So let's talk about some definitions. And depending on what state you reside in, there may be different terms for advance care documents. In some states, they will be called a living will, and in some states, they may be called a healthcare directive. But these are going to be written documents that helps you tell doctors and your healthcare team how you want to be treated if you are dying or unconscious and cannot make decisions about emergency treatment. They are not medical orders, so these documents alone will not guide first responders as a order for what they will do if they come upon you as a first responder in the community. These are really documents that are going to be for your healthcare decisions in a hospital or other treatment setting. Durable power of attorney for healthcare, healthcare agent, healthcare proxy, medical power of attorney. Those are the different definitions and the different terminology that reflect the person who can make medical decisions on your behalf at the end of life or any time you are not able to communicate. Certainly, it is best that these decisions are also guided by a written document, such as a living will or healthcare directive, that you have completed, but can be based on conversations that are strictly between you and the agent. And again, person cannot guide first responders in the treatment. That is through the discussion with the healthcare team and the physician. Let's talk about post, most. In many states, but not all, in many states, this is an approach to improving end-of-life care in the U.S. by encouraging providers to speak with patients and create specific medical orders to be honored by healthcare workers and first responders during a medical crisis. Again, not all states have this program. These are medical orders, although not all are completed under state statutes, and some are completed under more medical guidelines through the providers in that state. These are often defined as provider or physician orders for life-sustaining treatment, and these are going to be documents that the average individual who is healthy at present would not be completing, but as one's advanced age or illness come into play, these are the type of documents that would be added into the advanced care plan kind of grouping that you already have in place. There are also in many states, and some of the same states that have a POST form as well, but for many that don't have one that is utilized presently in the community, there are pre-hospitalization or DNR forms. DNR stands for Do Not Resuscitate. And these are state-specific documents that guide emergency medical and first responders regarding a patient's decision to forego resuscitative measures in the event of cardiopulmonary arrest. Resuscitative measures to be withheld could include chest compressions, CPR, assisted ventilation, endotracheal intubation, defibrillation, cardiotonic drugs that stimulate the heart. Not all state forms are the same. These would be signed by the patient, a designated proxy being the agent, and or physician, or somebody who is designated in that state, such as a A nurse practitioner can sometimes in some states sign these, a doctor of osteopathy, a physician assistant, but that is different in all of the states. These forms would be ones that are clearly posted or maintained near the patient. The fridge in one's home is a good location for the display of this form. And you can contact your non-emergency fire department number to ask for their guidance on the placement of form and where they would be looking for this if they were to be called in a 911 emergency situation. Again, these are documents that are not going to be on everybody's fridge when you're talking about a healthy individual. These would be ones of somebody where there would be less surprise if something were to happen in one's home that would require them calling for an ambulance or medical assistance. So when do you review your directives? I shared earlier that these are fluid documents. These are not a one and done. And I say that knowing how difficult it is already to complete this document once. So I understand that the idea of having to do it multiple times throughout one's lifetime seems daunting. However, again, it's really once the process has occurred, the changes are really going to more reflect changes that are happening in your own health or in your family structure. You have taken the important step of completing this directive, but you're not done. These documents need to continue to reflect your health care wishes and they will be best if you do review them on a regular basis so they continue to meet your needs. You should review your directives anytime your life circumstances change or one of the following Ds occur. Decade. It's a good way to remember to review your choices is on your birthday when you start a new decade. 30 to 40, 40 to 50, 50 to 60. Death. Certainly not one's own, but the death of a loved one causes us often to see our own healthcare choices differently. And in addition, the individual who has died may have been named as one of your document's healthcare agents, and you need to update this to involve someone else in that role. Divorce. If you experience a change in the makeup of your family, you will want to review your documents and consider updating them. Diagnosis. A new diagnosis of any serious health condition should also be a reason to look back to specifically talk with your physician about some of the issues that you may face with this new diagnosis and then put those in place in a new document. And decline. If an existing health condition should worsen, there may be potential complications not previously considered when you had made your original choices. What are some of the limitations to the healthcare document? Your agent must be at least 18 years old to be able to be listed as your healthcare agent, your proxy. You must be at least 18 years of age to complete. However, there are more and more states that have documents, particularly around those post documents, that do incorporate child decisions on there. So that in pediatric crisis advanced situations where there is an advanced illness, there are some documents that can incorporate some of the conversation with those younger than 18, however, recognizing who the legal guardian or agent is. These documents do not allow you to request healthcare treatment that is outside of reasonable medical practice. You can't, for instance, state that you would want a physician or a hospital to utilize medications or treatments that have not been approved for the diagnosis that you have or the situation you have, because they cannot do that within reasonable medical practice or legality. You cannot request those type of actions under the Death with Dignity guidelines unless it is legal in your state. So if those type of guidelines in terms of physicians working with clients at end of life are legal under the state statutes. You can then incorporate those into your documents along with working through the other guidelines and paperwork needed within your state guidelines for, again, things under the Death with Dignity Act. Resources and tools. I'm going to talk about some of the different resources that are available. There's a game almost called Go Wish. Seems like an odd thing to play a game with, but again, it allows conversation, and that's what gets all of this started. So it's called Go Wish, and it gives you an easy, even sometimes entertaining way to talk about what is most important to you. The cards help you find words to talk about what's important if you were to be living a life that may be shortened by serious illness. And you can play this game with your relatives or best friends, and it helps you learn how you can best comfort your loved ones when they need you most. And so these often will begin to start the conversation in a way that feels less awkward or difficult because it's just a kind of a back and forth. Talk with your physician office. Medicare does have some benefits for these type of conversations, and more offices and clinics are incorporating these type of conversations into groups that they offer at their clinic, as well as one-on-one conversations with your healthcare team members. There's a great program called the Conversation Project, and you can download what's called a Conversation Starter Kit at thoughtfullifeconversations.org. It's free, and it's something to incorporate and talk with your loved ones about. It gives you questions, kind of question starters for you to be able to think about. Your state attorney general office may have the documents for your state, and that's a good place to start, and those will have a lot of information about the different forms that are eligible in your state to be utilized. There's a program called honoringchoices.org, and on there are many different resources that are downloadable and with no cost. Well, these are older programs. I think they never go out of date. Primetime did an end-of-life planning program, and you can Google that and probably view it on YouTube, as well as Bill Moyers on PBS that did a program called On Our Own Terms. And these are videos and interviews along with some tools. I know that Bill Moyers has some checklists on kind of your own thinking about end of life and death and dying, and really great resources to be able to incorporate. I really encourage that this is a conversation. We get together with people who we care about and love all the time. We talk about many different things, but we often don't talk about the one thing that all of us know will at some point occur, and that is some point needed, which is what do we want for some of our healthcare wishes. I suggest when a next holiday comes up that you download your documents for your state, you roll them up and put a ribbon that represents the color of that holiday, and you start having some conversation. I worked with a woman who held off on serving Thanksgiving dessert until the adults at the party for Thanksgiving before they would have some conversation, after which she served dessert, but she wanted to get it going. And sometimes that kind of strange way of presenting it is the best way to kind of just move forward in the conversation. Agingwithdignity.org. While the 5 Wishes document is a wonderful conversation starter and has great open-ended questions to begin to explore values and the philosophy of life that can be used to complete documents, it may not meet all of your state guidelines, so you do want to think about how it can be incorporated, but it is, like the conversation starter, a great first step that really allows you to have open-ended conversation with loved ones, but really also to start with your own wishes about life. My Gift of Grace is a conversation game for living and dying well, and organizations can use this to transform the experience of these communications and conversations for staff, patients, families, and communities, and really can set it up to be able to be an activity game, and then move into having more one-on-one conversations with families and individuals. While you are typing in any questions, thoughts, conversations yourself into the question box, I will share that next month, May 18th, we will be having our webinar, and it will be the myths and facts surrounding senior mental health, something that is often, actually it is May 16th, Wednesday, May 16th at 3 p.m. Eastern. And again, mental health myths and facts for the senior population. So a really important conversation talking about, you know, what we often think about as some of the diagnoses from mental health for seniors, but what the reality is for them and for all of us as providers of care. I will be surprised if no one does put any questions or comments in the box. I know that there is a lot to have to think about, and so many of you may be really trying to kind of think about and formulate in your own minds how this plays out. I encourage you to go to any one of those resources to really, again, understand kind of your own belief systems, your own thoughts and feelings about this before you begin to have conversations with others. Your local Synergy Home Care office providers are always available to help share resources for your area. And so please don't hesitate to go onto the website, synergyhomecare.com, and be able to look up your local office, and they can help you for your area. I'll just give it another minute if there are other questions or comments. If you do want to receive your certificate of attendance for this, please email at Carla Sutter at synergyhomecare.com to receive your certificate of attendance. And if you do want to sign up for future events such as this, please go to the synergyhomecare.com website, sign up for the newsletter, and that will also allow you to have all of our upcoming events shared with you, as would joining us on Facebook, and we would also post any upcoming webinars or events there as well. If you have a question that you wanted to share more personally, feel free again to reach out, and I will ensure that you are routed to the right person to be able to answer your question. I really appreciate so many of you who joined today on such an important topic, and I hope that within the next few weeks or next month you've set some goals as to your own documents to have those conversations and complete them. So again, thank you for your attention, and we will see you again next month.